Welcome back to Sante Pharmacy Academy. I'm so glad you're here. This is video number 3 in our Ontario Minor Ailments series, and today we're covering calluses and cords. Whether you've had a patient coming complaining of a painful bump on their toe, or you've been wondering exactly when you can and cannot prescribe as a pharmacist, this video is going to walk you through everything, step by step. We'll cover the clinical difference between calluses and corns, how to assess your patient, the red flags you absolutely cannot miss, and the evidence-based treatment options available to you under Ontario's Minor Ailments framework. Okay, before we get started, I want to share a quick disclaimer. Everything in this video is intended for educational purposes for licensed pharmacists, pharmacy students, and healthcare professionals. This is not medical advice and it should never replace your own clinical judgment or your institution's protocols. And for full transparency, I have no financial conflicts of interest to declare. This content has not been funded or sponsored by any pharmaceutical company. And all of the treatment recommendations you'll see today are based on publicly available Canadian clinical guidelines. Let's take a quick look at what we're going to cover today. By the end of this video, you'll be able to define calluses and corns and tell them apart, including hard versus soft corns, ask the right assessment questions, and spot the red flags that should send a patient straight to referral. Apply the Ontario Minor Ailments framework to decide if you can prescribe. Select first-line treatments both over-the-counter and prescription level based on Canadian guidelines. And counsel patients on footwear, self-care, and how to prevent recurrence. This is very practical topic, the kind of things that comes up at the pharmacy counter multiple times a week. So let's get into it. So let's start with the basics. What exactly are we dealing with? Both calluses and corns are forms of hyperkeratosis. That's just thickening of the outer skin layer, but they're different in how they look and feel. A callus, medically known as a tyloma, is a diffuse, broad thickening of the skin. It has poorly defined borders, it's usually not very painful, and it forms in response to a repetitive friction or pressure, most commonly on the heel or the ball of the foot. And think of it as a body trying to protect itself. A corn or clavis is different. It's a focused, cone-shaped thickening with a central core that points inward. That's what makes it painful. Hard corns form on bony prominences, especially the top of the toes. Soft corns form between the toes where moisture keeps the skin macerated and white looking. So the key distinguishing feature here is corns have a central translucent core, calluses don't. Now, why do these form in the first place? The mechanism is pretty straightforward. When the skin experiences repetitive mechanical stress such as friction, pressure, shear force, the epidermis responds by proliferating. The stratum corneum gets thicker and thicker. At first, this is protective, but when it becomes painful or interferes with walking, it's now a problem that needs treatment. The most common causes include ill-fitting footwear. This is the number one culprit. Tight shoes, high heels, narrow toe boxes. Abnormal gait or biomechanics, flat feet, hammer toes, bunions, anything that changes how weight is distributed across the foot. Occupational factors, people who stand for long periods or do repetitive manual work. Aging, as we get older, the fat pads in our feet thin out and skin becomes less elastic. Always always ask about footwear. It's the root cause in the majority of cases and the key to preventing recurrence. Great news for anterior pharmacists. Calluses and corns are included in the minor ailment list, which means we can assess and prescribe for condition independently. But, and this is important, we still have to meet a specific criteria before we do. For a patient to be eligible, the diagnosis must be confirmed as a callus or corn, not a wart, ulcer, or other lesion. There must be no contraindications, no diabetes, PVD, neuropathy, or immunocompromise. The severity must be mild to moderate. No infection, no ulceration. The patient must consent to the treatment plan. If any contraindication is present, you do not prescribe, you refer. We'll cover those red flags in the next slide. When a patient comes to you with a foot complaint, you're going to use your Scholar MAC framework. Let me walk you through the most important questions for the specific condition. Symptoms and characteristics. Where is it? Is it painful? How long has it been there? Is it hard, soft, or diffuse? Do you see clear borders? History and onset. Has this happened before? Did it start after getting new shoes or starting a new activity? Medications. Are they on blood thinner or immunosuppressants? Have they already tried any treatments? Allergies. Any allergy to salicylates? Sensitivity to adhesive plasters? Conditions. The critical one. Do they have diabetes, PVD, neuropathy, or any immunocompromising condition? If yes to any of these, refer immediately. Always visualize the lesion if possible. Diagnosis is largely clinical and based on appearance and location. This slide is one of the most important in the whole video. These are the red flags that require an immediate referral. Do not treat these patients in pharmacy. Diabetes. Any foot lesion in a diabetic patient, no matter how minor it looks, requires referral to a podiatrist or physician. Full stop. Other red flags include peripheral vascular disease or poor circulation, cold feet, color changes, absent pulses. Peripheral neuropathy. The patient can't feel pain or sensation in their foot. Any signs of infection, redness, warmth, pus, fever. Ulceration or open wound associated with the lesion. Suspected plantar wart looks similar but is managed very differently. Immunocompromised patients, transplant, HIV, systemic steroids. No improvement after 4 to 6 weeks of appropriate treatment. Uncertain diagnosis. If you're not sure what it is, refer. The diabetic foot rule is non-negotiable. Salicylic acid is absolutely contraindicated in diabetic patients. Before we reach for a prescription pad, we always start with non-pharmacological measures. In fact, for many patients, these alone are enough to resolve the problem. There are 4 key areas. Footwear modification. This is first line. Proper fitting shoes with a wide toe box and low heel. cushioned insoles or custom orthotics if biomechanics are the problem. Mechanical debridement, soaking the foot for 10 to 15 minutes in warm water, then gently using a pumic stone or foot file in circular motions. Important. Remind patients to never use razor blades or sharp instruments at home. Protective padding, donut-shaped pads, toe separators for soft corns, silicone toe sleeves. These offload pressure from the lesion while it heals. Lifestyle and prevention. Daily moisturizing with a urea-based cream, moisture wicking socks, and regular foot inspections. Emphasize to patients. Treating the callus without fixing the footwear is like treating a rash without removing the allergen. It will come back. When non-pharmacological measures aren't enough or the patient needs faster relief, we move to pharmacological treatment. The first line agent is salicylic acid. Salicylic acid is a cratolytic. It works by breaking down creatine, softening and loosening the thickened skin so it can be removed more easily. Let me walk you through how to use it. Over-the-counter concentrations of 17%. Products like Compound W or Dr. Scholl's are appropriated for most mild cases. As pharmacists under minor ailments, we can prescribe higher concentrations up to 40% plasters or gels for more significant lesions. Application technique matters. Apply only to the lesion, not the surrounding skin. A ring of petroleum jelly around the lesion protects healthy skin and use daily. How about the duration? Typically 2 to 4 weeks for corns, 4 to 8 weeks for calluses, and reassess if no response. Urea creams, a concentration of 10 to 40%, are also very useful, especially for calluses. They hydrate and soften the skin, and higher concentrations have a true cratolytic effect. So these are available over the counter and are a great adjunct or alternative for patients who can't use salicylic acids. And again, salicylic acid is contraindicated in diabetes, neuropathy, peripheral vascular disease, and broken or infected skin. There are three special populations worth highlighting specifically. Diabetes. I'll say it again because it bears repeating. Any foot lesions in a diabetic patient is a referral. Diabetic have impaired wound healing, reduced sensation, and poor circulation. What looks like a simple corn can become an ulcer, an infection, and in severe cases can lead to amputation. Salicylic acid is absolutely contraindicated. Second group is elderly patients. Older adults are more prone to calluses because their fat padding thins over time. Before treating, check for vascular insufficiency. If the skin is fragile, urea cream is preferred over salicylic acid. Also consider whether the patient can safely perform self-care, can they see their feet clearly, can they reach them safely. Last group here is pregnancy. High concentrations of topical salicylic acid should be avoided in pregnancy. Mechanical methods such as pumic stone, padding are the preferred approach. Urea creams are generally considered lower risk. When in doubt, recommend conservative measures, and consult with the patient's obstetric care team. Now let's talk about how to counsel patients effectively. These are the 6 key messages I want you to walk away with. Number 1, explain the cause. Calluses and corns aren't infections. They're mechanical problems. Address the friction and the pressure, and you address the problem. Number 2, teach proper salicylic acid technique. Apply only to the lesion. Protect surrounding skin with petroleum jelly. Use daily and never unbroken or infected skin. Number 3, no self-surgery. No razors, scissors, or corn cutting kits at home. This is especially dangerous in diabetics and elderly patients. Number 4, fix the footwear. Even the best treatment will fail if the patient goes back to wearing the same ill-fitting shoes. Number 5, set realistic expectations. This takes weeks, not days. If they're not seeing any improvement after 4 to 6 weeks, they should follow up. And last but not least, number 6, know when to come back. Worsening pain, signs of infection, or no improvement. Those are reasons to return. Patients often come in frustrated after trying over-the-counter products that didn't work. Ask about technique. Most errors are application errors. Let's bring it all together with a quick clinical decision summary. This is the 4-step approach I want you to use every time. Step 1, diagnose. Confirm it's a callus or corn, not a wart, ulcer, or other lesion. Look at location, shape, borders, and the presence or absence of a central core. Step 2, screen for red flags. Ask about diabetes, peripheral vascular disease, neuropathy, and signs of infection. If any red flag is present, refer. Do not treat. Step 3, confirm eligibility. Check minor ailments criteria are met. No contraindications. And patient consents. Step number 4, treat and counsel. Start with footwear advice, padding, and mechanical debridement. Add salicylic acid if needed. 17% over the counter or up to 40% prescription. Urea cream as an adjunct. Set follow-up expectations. This 4-step flow works as a mental checklist every time a patient presents with a food complaint. And this is a wrap up on video number 3, calluses and corns. I hope this gives you a really solid foundation for the next time a patient walks in with sore feet. You now know how to diagnose it, how to screen for red flags, and how to put together a complete treatment plan as a minor ailments prescriber. If you found this helpful, please give the video a like. It genuinely helps other pharmacists and students find this content. And if you haven't subscribed yet, please do. We have a lot more coming. And our next video is going to be video number 4, candidal stomatitis, also known as oral thrush. That's a great one, so stay tuned. If you have any questions, drop them in the comments below. I read every single one. See you in the next video.